All right, good afternoon, everyone, and welcome to the September Optimizing Newborn Nutrition webinar. We have a full session for you all today. We're starting with leveraging data and QI methodology for optimizing newborn nutrition, and then associations between breastfeeding and post-perinatal infant deaths in the U.S. I have a couple of updates for you all before we get into the rest of our webinar. I first want to thank Children's Healthcare of Atlanta's Eggleston NICU for hosting members of the GaPQC Neonatal Committee for a site visit. We're testing out a new site visit process where we visit participating GaPQC ONN hospitals to learn about their infant nutrition practices and what their implementation of optimizing newborn nutrition looks like. We are refining our site visit process and we hope to do more in the future, so look out for more information on that opportunity to host members of the neonatal committee for a site visit.
No,
We're also
because you guys held me hostage, remember?
And we've sent out a couple emails on this. I just want to do one more reminder that we are excited to support 2 to 3 registrations per GaPQC participating hospital to attend Emory Decatur Hospital's 9th annual perinatal conference. It is coming up soon. It's September 21st and 22nd. I will make sure that the flyer goes out in the follow-up email to this webinar. I'll also put it in the chat, and I'll put the code for registration to make sure that your registration cost is covered. I'll make sure that's in the chat as well. And there is CNE 12 hours of contact hours, 12 contact hours for this conference. And now I'm going to hand it over to Dr. Ravi Patel. He is our GaPQC and neonatal chair, and he's going to talk about leveraging data and QI methodology for optimizing newborn nutrition, a focus on testing and the PDSA.
All right, let me share my screen. Good afternoon, everyone. Glad to see all of you on the webinar. Can you see my screen, Kimberly?
Yes.
Okay, perfect. So I really wanted to talk about, we've done, and all of you at the hospitals have done a lot of work on collecting audits, setting your aims, performing key driver diagrams to kind of set a theory of improvement. And now really what we've talked about, we went on this in December of this past year, really thinking about how we can test and accelerate change. And so that's going to be the focus of today, a little bit of QI methodology and sharing also some of what you have been telling us about changes you've made. And that was something we've added to the monthly audit. So it's nice to get a sense of what are the changes that hospitals are making as part of this initiative. So I'm going to talk a little bit about QI methodology and talk a little bit about PDSA cycles and testing as part of that in terms of how we might use that to accelerate improvement. And one of the things is, QI methodology is not rocket science. And that was really intentional for the people who developed the Institute for Healthcare Improvement model for improvement, was really to make this model be very tangible and accessible to any center, to really be practical and not to make it complex. Now, there are other different models that might, improvement models that some of your hospitals might use that are a little bit more technical, but really the model for improvement asks 3 fundamental questions. And those 3 questions that this model is asking is, the first one is, what are we trying to accomplish? And I think this is what we've worked on, is what are you trying to accomplish? And so for the GaPQC as a whole, for Georgia and the hospitals that are participating, our goal as a collaborative and our SMART aim is to increase the percent of newborns in the GaPQ hospitals that get human milk as their first feeding by 10%, from 73 to 80% by the end of this year. So this is what we're hoping to accomplish together. But for your individual hospitals, I would say, hopefully at this point, and we've had a chance, thank you for those of you, I think many of you have sent in your SMART aims of saying, this is what you are trying to accomplish at your hospital. That has to be step one. And that's why we've worked on, and we talked about SMART aims early on in terms of thinking about what you're hoping to accomplish by participating in this initiative. We also realize that some of you are at hospitals that are just joining, or individuals that are just joining to learn, and we're really glad to have you. And so this might just be an opportunity to learn, and I think that's fine. And we're this is an excellent opportunity to get some change ideas and just to learn about neonatal nutrition. The second is, how will we know that a change is an improvement? And one of the core features and one of the efforts, and I know this has been, we're thankful for all of you at the hospitals for collecting this data, is how do you actually know if you make these changes that you're actually improving? And this is a fundamental aspect of quality improvement, is you have to measure change, or you have to measure what you're trying to improve to know if it's actually improving. There's a whole aspect of just general operations of a unit or a hospital where you write policies and procedures, and that's important. That's part of the operations of the unit and your daily practice and how hospitals will function. But QI is a little bit more than that. It's not just doing that, but also measuring to say, how are we doing? And how will we know if we make changes that we're actually improving? And critical to that is measurement. And so I wanted to start really by thanking all of the hospitals. We've really had a great level of audit completion over time. And so this has really been important for us. We can't measure and know how we're doing both at the individual hospital level and at the GaPQC level if you all aren't doing these audits and measuring. And so thank you to all the hospitals, and also big thanks to Linda Pham, who is a perinatal data manager at DPH, who's been helping us with collating these reports. So how are we doing? And we give these updates quarterly. You receive these reports. And so this is our last quarterly update on our primary measure for the overall collaborative, which is human milk as a first feeding. And so we have a good sense of how Georgia as a whole, as part of the GaPQC, is doing on this measure. It's about 72, 73% is our baseline. And so this gives us a good sense, and it's a pretty stable baseline. Actually, if you look at over the last year, this is where we stand. And so this is consistent with what we set out as our baseline performance. And our goal by the end of next year is to try to see if we can move this needle and move this measure. This is a tough measure to move. Hospitals have been working on this for a number of years. And I think one of the things that's very helpful is this is the first time we actually can get in pretty close to real time a sense of how we're doing as a state. This is formula in the last week. About half of newborns in Georgia hospitals are participating in this collaborative, either in the well newborn setting or in the neonatal intensive care unit, are getting formula in the last week. And then this is breastfeeding, timeliness of breastfeeding expression within 6 hours. And this was based on work from other collaboratives and guidance from organization. So this is the measurement, and why I think it's important to measure is we have a good sense of how we're doing. Before July of 2022, July of last year, we couldn't even give you a good estimate of how we were doing with these measures, and now we know. So thank you for doing that, and I hope this gives you an idea of the importance of that. So really that's part of it, but we don't just want to measure. We really want to go beyond measurement. Measurement is critical, but we really want to think about how we can make changes. And those changes we need to think about using QI tools. And so one of the first QI tools, and one of the things we worked on earlier this year, is really thinking about key driver diagrams and using that one improvement tool as a framework for how you can think about what are you trying to improve and what are the drivers of that aim that you're trying to improve, and what are the potential interventions or changes you can make as part of that aim. And one of the goals for our monthly webinars has been to give your team change ideas and go through potential changes in practice, potential things that you might be able to do, changes that can address those drivers and improve your aim. And so many of your hospitals have shared with us your key driver diagrams. If you haven't had a chance to do this, I'd really encourage you to reach out to us if you're struggling with a key driver diagram, and we can help work on that. You can always adapt, and this is the one that we developed as a broad key driver diagram when we started this initiative for the overall GaPQC, where we're trying to move the needle on these measures. And there are many different drivers that influence this, and these might differ depending on your context in your hospital, and a variety of different interventions that you could pursue. And many of our webinars that we've had in the past, some of the micro lessons that you all have access to, all of those are really tied to give you ideas and knowledge about how you why some of these interventions might be important, and and maybe how you might consider testing and implementing them in your hospitals. So one of the things we really want is just change ideas, but we also want to make sure you try these out. And so that's one of the focuses, and one of the things I wanted to talk to you about today is not only just thinking of these ideas, but actually testing them in your hospitals. That you think, well, I've listened to this webinar, this seems like a good change we can make. Let's try this out. And to do that before just broad implementation. And so when we think about testing, and this is where the Plan, Do, Study Act, or the PDSA cycle comes in, I thought it was good for us to talk a little bit about PDSA cycles. And what are they? Well, one of the things for the PDSA cycle is if you're trying to make a change, you want to see if it's actually going to work or not. And ideally, you want to do that in a small scale, small number of patients, maybe one patient, one day of the week, one shift, and try to see if it works and predict what will happen, and then use that learning to then decide what to do with that change. So part of the effort of the test of change is to develop a plan for this change that you're going to try making, carry out this test, ideally in a small scale. And this allows you an opportunity to say, we tried this out and we identified these potential problems or unexpected observations on a small scale. And that allows us to then learn before we make this big change across our hospital and train a bunch of staff and educate a bunch of our staff and then realize potential unanticipated problems. And then once you do these small tests of change, analyze what happened or discuss what happened, summarize what learned. This doesn't have to be very labor intensive. And the key here is once you do that, you might either adopt it and say, oh, this change we made worked, and let's adopt it and let's implement it. You might adapt it and make some small changes and tweaks to say, this kind of works, but we need to change. And I'll give you an example. We need to change this around because of some of the problems with what we tried. Or you might abandon it and say, no, this seemed like a good idea, but it really was challenging to make this happen. We're not going to put a lot of energy in this. And we might work on some of the other interventions on our key driver diagram, or we might think about maybe waiting on this and coming back to it later. And the goal for this idea of why it's cycles is that you then can take what you've learned and try it again in a larger group of patients in a different setting. Potentially, if you started it in just one day a week, you might do it now for a whole week and see what you learn from that. You might do it from a small number of patients to a large section of your unit or your setting. And this allows, the goal for these PDSA cycles is learning. Your real goal is when you're making these changes, you think that these ideas are going to lead to improvement. You want to learn on a small scale, what are the barriers? What are the things that might be challenges before you put a lot of effort and investment in terms of ramping this up? We'll share this, but this is you don't have to use this, but this is a little bit of a formalization of actually a test of change. If you're doing this in terms of teams where you might have an overall aim, this might be your SMART aim. Your test doesn't necessarily need to be your SMART aim. Your SMART aim might be increasing breastfeeding or expression within 6 hours of birth. Your test might be, should we deliver the hospital grade breast pumps to the bedside in the labor and delivery room, or should we deliver it in the postpartum setting? That might be the objective. It might be tied to this, but the objective might be a very specific test. You might describe it. You might say, what are we expecting to happen when we make this change? Which of our drivers from our key driver diagram is this test aimed to change? And what do we think is going to happen? This is good because you want to know, is this going to succeed or not? This is a way to at least formalize what your goal for this test is. And then list who might be involved with that. Did you actually do it? It might be, no, it didn't get carried out because the person who was supposed to carry it out wasn't able to do it. We learned from that and maybe change the people that are involved. Or you pick up unanticipated observations. And once you have this information, this can then be used to make a decision. Do I want to change something about what we tried out? Do I just want to adopt it and then work towards implementing it broadly? Or do I really want to abandon it and try a different idea? You don't have to fill out every piece of this, but this I think can be a tool or a worksheet that helps you think about how you might apply changes in a more formal way, in a more structured way. And ideally, this can be shared with everyone on the team so people are clear who's responsible for what and where. So this is an example of a PDSA change for information about hepatitis B vaccination. So you might do a very small test, which is, I really want to give a new, we've had a lot of declines in hepatitis B vaccination. We really want to test this new information sheet for parents. And so we're going to test this information sheet. We're just going to do an N of 1 test. And this N of 1 test is going to be one nurse is going to give this to her first patient on Tuesday and get feedback on what she thinks. And ask the mother if we can get her to give feedback on what she thinks about this new information sheet. So the new sheet's handed out, feedback is completed, and you get this from the mother. And really the feedback is it was really hard for the patient to read the font. And some of the language was hard to understand. And so you might adapt based on that small test of change to say we really decreased the reading level, we increased the font size, and now we're going to ask Judy or maybe another nurse to test it on 4 of her patients to get more feedback. And what you can do is you can identify changes very quickly that might improve this before you go out and print 1,000 sheets and put them into and distribute them to all your unit and make a new process and then realize, oh, we should have made these changes. So this is just one example of small test of change that then can be adapted as you go forward. I think one of the keys in quality improvement methodology and science is that testing does not equal implementation. And so if your first change is to implement something, as you're thinking this initiative, if you're making a change that's broad scale implementation of we're just going to make this change today for every baby in our unit or in our hospital, let's say you want to take a pause and step back and say, we really, before we make this big change, let's make sure we get this right, because this change could continue on in our unit for years and years and years. We maybe want to make sure we've kind of thought out about all the kinks related to this change. And so I think testing can be really useful for on a smaller scale before you implement something, really thinking about that. And then as you do that, I think you really get a lot of learning and you can be more confident that the changes you made, whether it's an information sheet, whether it's a change in your process, that it's going to work. So you start small, and then as you learn, you kind of scale up in terms of broadening the testing to more patients, more staff, more units, and you start to learn. Eventually, you're pretty confident that this change you're proposing, this intervention is going to work. And at that time, or you've been able to remove some of the barriers to that change happening, and now is a good time for implementation. So this might be this is just me as giving an example of you're trying to improve the timeliness of milk expression. And so one of the ideas is maybe we should have a goal to move the breast pump within 3 hours of birth to be in the room so that a mother who's delivered a preterm infant who's going to be in the NICU can start feeding quickly. But as you trial that out, you realize often in the unit that actually they're not in the postpartum room where we're stocking these breast pumps. And so they're often still in labor and haven't been transferred. And so maybe we really need to change where we do this. So that's one change that you might learn from. And then you start to do that in your labor and delivery setting, but now there's not enough pumps. And so maybe you now really need to think the process. And then as you do that, you realize these pumps are getting left in the room. And as the patient moves from labor and delivery to postpartum, that the pumps aren't moving. And so you need a new process to make sure that there's a way for these things to move with the family. And so once you work all this out, you eventually get more confident in this new process, which might be a change for your goal in your unit to improve the timeliness of breastfeeding and milk expression within 6 hours of birth. This might be one of those things you're changing, but you've kind of tested it out so that once you implement this, you're confident you've addressed some of these barriers. And so PDSAs are more than just collecting data. They're more than education only, more than developing policies or protocols or implementing a solution. They're really trying to test something until you're reasonably confident that what you're trying to do will actually happen as you intended to do. And then these 4 things are critical parts of that. educating staff about it, developing. Once you're confident and you want to implement it, I think it's really important to develop policies or protocols and implement them, but really to try for some of these changes to try it on a small scale. And then once you're confident about it, that's a good point to then start to develop these into written policies, incorporate a standard workflow, train broader. So instead of just that small test of change that might involve a limited set of providers or clinicians, you can now provide broader training that might be more labor intensive. And it might then at that point, once you're more confident might work, might then be something you can make the necessary investments in, which might involve purchasing items, maybe hiring new people, changing schedules, or et cetera. But you don't make those necessary changes unless you're reasonably confident that these changes are actually going to work as intended. And at that point, it still does, once you make these changes, still does require some day-to-day feedback before it becomes what we call routine work or part of the standard process. And if it's not happening, you might actually have to go back and still test and work out the kinks of what's going on. So it's been really exciting to see, and thank you for those that submitted that. We've had about 50% of the GaPQC hospitals participating in optimizing newborn nutrition shares and that they've made changes to care processes, policies, or procedures in the past year. And so these are things that we really want, because our goal is eventually what are these changes that we can make to result in improvement, and so we're glad to see this, and we want to we'll continue to kind of assess some of the changes and learn from you, and hopefully as we progress and at our meeting next year we can actually have some of our centers even maybe later this year present what are some of these changes that have been happening. So I'm just going to share a few of these, and it's great to read these. This is just from some of our centers, what you shared from us. And so this is one center that really had, each unit had breastfeeding goals as their metrics. They were each participating in creating the key driver diagram. These are discussed at leadership meetings, so there's a lot of visibility for this. These metrics and charts are made into slides to present. So this is great to see. We are giving these reports for you. Really, we want those reports not to live in somebody's inbox. We want those reports that we're sending back to your hospitals to really be shared so that everybody has visibility in how we're doing. And then there's communication to see what we're doing and really being focused on goals and what improvements can be made. So this is great for whichever hospital sent that in. There's some changes related to donor milk and changing and broadening categorization. This seems maybe to relate directly to the formula feeding the last week. And so that was something that's been done. And then there's been some efforts on lactation breastfeeding education within 24 hours admission and feeding protocols and feeding faster. So these are from different units, both from the well newborn and the neonatal intensive care unit. Some efforts on breastfeeding checklists. Checklists are a great way to, a great QI tool, hand expression, a NICU-specific lactation specialist, encouraging rooming in and information about rooming in, and then addressing if things are problems, better understand why, for example, formulas being used if not requested. So these are at least some of the changes we really look forward to thinking and using really as you're listening to the webinars, viewing the micro lessons. Think of those and ideas of what are the changes that might be that it could occur. And these are going to be very context specific. So these are things that are relevant to your local context of care, the things that that might be feasible in your setting. So I really wanted to finish with highlighting what I really think is possible, and one of our things is to cut the impossible out and make things possible. And one of the goals we have is to really see you as hospitals make improvements in these measures that we've been measuring. And I wanted to really share some very exciting snippets, and these are kind of some early peaks from anonymized measures. These are all of four different hospitals that have been participating in our optimizing newborn nutrition initiative, some of these in the well newborn or NICU setting. And so just to highlight, some of you are really making some changes, and we're able to start seeing these. You can see human milk as the first feeding, really this going from a baseline of around 20%. This unit has really kind of moved that up. You can see a group that started at 60 to 50% breastfeeding expression within 6 hours, really remarkable now at 80 to 100%. This unit right here has really seemed to have dropped their formula supplementation in the last week from about 80% to 40 to 30%. And this NICU right here is really, you can see here, has improved breastfeeding expression within 6 hours. So these are just nice snippets of actually what our Georgia hospitals have been able to really do. And some of these are going to be hard things to move. There are other, I share 4 examples. There are people that might be trying a lot of changes and may not be moving the needle. And I think it's good that that is part of quality improvement. Go back to your charts, go back to your key driver diagram and say, okay, we've tested and tried this. What else can we do? But these are things that we hope for these 4 different hospitals that these charts are from, that we might be able to learn from you, and you can share what you've been doing to see some of these changes that have happened. And then sustainment is important. So this is another hospital, and you can see sometimes you can have improvement, but decay is possible. And so this is why we want to track data over time and follow it and keep monitoring. And you can see things dip, but then you can get back up. And what your goal is to make sure that this gets sustained and implemented so it becomes part of the routine process. So with that, I'll finish up and thank you all for listening. And we hope for some of those centers that we've shared on here that we can hear, we can ask you and maybe request you to come on one of these webinars and share what you've been doing.
Thank you, Dr. Patel. Before we move to Dr. Ware's presentation, are there any questions or comments from anyone? Okay. It's great to see the improvements. So proud of these hospitals. It's so exciting. All right, I'm going to hand it over to Claire Eden with Georgia AAP to introduce our next speaker.
Thank you, Kimberly. And I'm really pleased to introduce Dr. Julie Ware. And I'm also just thrilled that she got to hear all of and see some of the great work that we've been doing here in our initiative. Dr. Ware is an experienced board certified pediatrician. She specializes in breastfeeding medicine. She joined Cincinnati Children's Hospital Medical Center about 9 years ago as a member of the Center for Breastfeeding Medicine and the Community Breastfeeding Liaison. Her particular interest is in improving maternal and child health through the promotion and support of breastfeeding, especially in those populations least likely to breastfeed. Her research and community efforts are focused on the elimination of disparities in breastfeeding, which is, of course, why we've invited her to come speak today. Dr. Ware received her undergraduate degree from the University of Texas and completed her MD and pediatric residency training at Baylor College of Medicine. After many years of general practice with a focus on breastfeeding medicine, she completed an MPH degree not so far away from us here in Georgia at the University of Memphis. And she's also an internationally board certified lactation consultant, or IBCLC. Dr. Ware is currently on the leadership team of the Southwest Ohio Breastfeeding Coalition, a member of the Ohio Chronic Disease Collaborative Breastfeeding Work Group, participates on the Ohio First Steps leadership team. She is one of the Ohio AAP chapter breastfeeding coordinators and co-founder of the All Moms Empowered to Nurse, or AMEN, support group. Welcome, Dr. Ware.
Thank you so much for that introduction. Let's see if this works here. All good?
Looks
You guys
good.
can. Okay,
Yeah.
great. All right. Thank you so much again for inviting me. And it's not only a little bit close to Tennessee, where I'm previously from, but I was quite involved with the GaPQC program there. And so listening to your tests of change and looking at the improvements you're making in breastfeeding is bringing back wonderful memories, and I'm very proud of what you're doing. So I will be talking today about breastfeeding and postperinatal infant death in the United States. Nothing to disclose. I do want to mention this is not an official CDC talk, but it has been approved to be presented by the CDC as one of the co-authors of our published papers. So I hope we can identify the association between breastfeeding and postperinatal infant mortality and explain the opportunity for breastfeeding promotion, protection, and support to be in infant mortality reduction initiatives. So we got to start with breastfeeding. We just finished National Breastfeeding Month. I bet you guys had a lot of fun things happening in Georgia. But this is a snapshot map of breastfeeding across the United States. In this particular CDC map, the light colors are the lowest breastfeeding rates, and the darkest colors are the highest breastfeeding rates, which we know to expect that in the Northwest, highest breastfeeding in the Deep South and some of the Midwest, lowest breastfeeding rates. And Georgia's green, so good. um, Breastfeeding disparities exist and persist in the United States. So these data are from the National Immunization Survey, where we look at any breastfeeding at 6 months, 12 months, exclusive at 3 months and 6 months. And you can see that we have disparities, specifically if you look at the yellow bars, which is non-Hispanic white mothers, compared to the purple bars of non-Hispanic Black mothers. There's a big difference at all time points that are measured by our National Immunization Survey. And this is your newest Georgia breastfeeding rates. So Georgia rocked it. The turquoise color is, you superseded the United States for your initiation. And I wonder if it's some of your great work with GaPQC. So very, very nice. And then there's some room for improvement after getting started, which we all have across the United States. The pink bars are those lofty goals we have for Healthy People 2030 for breastfeeding at 1 year and 6 months. And I hope you all have seen the United States Breastfeeding Committee report for Georgia. I just pulled this snapshot out to highlight the WIC breastfeeding performance measures. We all have room to improve. You look at the far right, from fully formula fed for Georgia, WIC is 72% compared to national WIC 66%. However, if you look at Georgia's number of live births in baby-friendly facilities, you supersede the U.S. national once again at 32% in baby-friendly facilities, and you have the early childcare licensing breastfeeding support going on with a high score there. So a lot of great things are happening in Georgia. I hope you have seen this CDC map for county breastfeeding initiation. Now, these data are related to the actual birth certificate, which we'll be talking about today. And this is really important when you're drilling down, like Dr. Patel was talking about, thinking small. Each little county across the U.S., we all have our own issues to deal with, and it's really nice to have this data by county for the nation. And this is the map by county for Georgia, and in this particular map, the dark color is the lowest breastfeeding rate and the lightest color is the highest breastfeeding rate. So some of your counties are almost 90% initiation, and then some are much lower. So we know where we need to be active. Now I'm going to switch gears just a minute to talk about infant mortality, and then we'll tie them together. Infant mortality is defined as the death of a child before the first birthday. The infant mortality rate is defined as deaths per 1,000 live births, and we know this is an overall indicator of a nation's well-being. And the U.S. infant mortality rate is higher than other high-income countries. So you can see where we are right there, and just blowing that up, you can see we have a lot of improvement we need to do in the United States for our infant mortality. Our overall infant mortality is 5.8 deaths per 1,000 live births, but that's overall, and we'll be talking a lot about the disparities in a moment. But our goal for Healthy People 2030 is 5.0 deaths per 1,000 live births, and I would hope that we're going to make a loftier goal than that for our nation. Our leading causes of death are congenital malformations, short gestation, maternal complications of pregnancy, sudden infant death syndrome, and unintentional injuries. And we look at our U.S. infant mortality rate by state again, you see in this map, the dark is the highest infant mortality, and the light green is lowest infant mortality. And again, Georgia is not in the lowest section. So Georgia has some really good things going on. This is a trend graph that is just so powerful to me. When you look at back at 1915, and the infant mortality rates were sky high when you looked at all races, white and black. And then over time, thankfully, they have decreased in all races, white and black. However, that little squiggly gray line that you see rising over time is the black-white ratio. So now it's over 2 times as frequently a black baby will die compared to a white baby in the United States. And that is a disparity that's just unacceptable. When you look at the vital statistics data for this most recent year, you can see the non-Hispanic Black infant mortality rate was 10.6 compared to non-Hispanic white of 4.5. So again, over 2 times higher. And then they actually look also at different regions, and Appalachia and Delta have much higher infant mortality rates than the rest of the United States, as you see on the right, and nicely coming down. We're very happy about that, but still that disparity is not really shrinking. And Georgia there's a part of Georgia that's part of Appalachia. So we again, we all have work to do. I got this from your Department of Health, and it was very powerful to see how they're highlighting the work to be done. 2 babies will die today in Georgia, and that there's 5.4 non-Hispanic white deaths per 1,000 live births compared to that 12.2 for Black infant mortality. And so again, that over 2 times increase we see here. And I really liked how they pulled out your county data and called it excess infant mortality. And you can see the counties here that are problematic with the orange color is the biggest trouble areas. But when we talk about breastfeeding, I can tell that everyone here knows all this, but we know that breastfeeding is a normative standard for infant feeding and nutrition with a reduced risk of a lot of diseases, both acute and chronic, and even some associations with reduced death. So we've seen reduced sudden infant death syndrome with any breastfeeding for 2 months. In developing countries, there's been up to a 14-fold increase risk when there's no breastfeeding versus exclusive breastfeeding. Of course, necrotizing enterocolitis has a lower risk with exclusive human milk diet, and you guys are really rocking that. And then we're going to talk about the first study about postneonatal mortality in the US with any breastfeeding, which was published in 2004 by Drs. Chen and Rogan. And they did their study based on a sample from the 1988 Maternal and Infant Health Survey. And they did a case control study. They excluded all deaths less than 28 days and those from congenital anomalies and malignancies. And their controls were the live-born children surviving the first year, and their exposure was breastfed ever versus never. And overall, their adjusted odds ratio was 0.8. So a reduction in the odds of post-neonatal death by 20%. And this held for Black and non-Black babies as well. So now I'm going to switch over closer to you down in Memphis when I spent time there and talk to you about what Dr. Chen and Rogan's study prompted us to look at in Memphis. Memphis had a terrible infant mortality problem. It still does, but it is improving. And in 2005, when this picture was taken, this was a community grave site where our babies were buried together because there were so many of them. And this article was entitled Born to Die. When we started looking at the data over time, we started to see this inverse relationship. But if you look on the left of your screen, that's infant deaths per 1,000 live births, and the blue triangles are our Black infants. And you see we were almost up to 20 deaths per 1,000 live births back in 2005. And over time that decreased, not still by any means where we want it to be, but at the same time, breastfeeding was increasing from a low of 30% in our Black infants up to almost 60% over that 11-year period. So we decided to take Dr. Chen and Rogan's approach, only look at the birth certificate data linking to infant death certificate for our entire cohort. And we excluded less than 500 grams and less than 7 days, also congenital anomalies and malignant neoplasms. And we had 148,000 live births and almost 600 live infant deaths. We looked at many covariates that were associated with both conditions. And we found, similar to Dr. Chen and Rogan, an adjusted odds ratio of 0.81 for any deaths over 7 days. When we looked at late neonatal, just the neonatal period, an even greater reduction was noted of an odds ratio of 0.49. The postneonatal mortality was less in our group of 0.95. So this led our CDC colleagues to say this would be a good study to do for the entire United States. So it was really the honor of my life to work with the colleagues in the CDC and Dr. Chen and local colleagues to look at this same problem across the United States. So we did the same connection between live births and deaths through the National Vital Statistics System. And by 2016, all 50 states adopted the birth certificate revision, which does include the question, is the infant being breastfed at discharge? So we were able to pull that feeding information out. At that study, we had over 3 million births with 22,000 deaths, and we used the same exclusion in the Memphis study, although California and Michigan births were also excluded because they were not reporting or reporting inconsistently to the CDC. There were finally then 69 post-perinatal deaths that we looked at, dividing into late neonatal and post-neonatal. Again, looking at lots of covariates affecting both conditions. And the results, you see the demographics of our group mirrored the population, as you might expect, with 20% Hispanic, 50% non-Hispanic white, 15% non-Hispanic Black. Most mothers had prenatal care and were non-smoking. A lot of overweight and obesity, as we know, in our country, and about a third cesarean section, and close to 10% either in your NICUs or preterm or low birth weight. And so again, we're finding similar results in this study for the entire United States with an adjusted odds ratio of 0.74 for 7 to 364 days. And we also looked at stratification by race. And you can see it holds for all groups: Hispanic, non-Hispanic, white, non-Hispanic, Black, and non-Hispanic Asian. And it held in the late neonatal period and the post-neonatal period. The causes of death we looked at and were significant were infection, sudden unexpected infant death, unknown and necrotizing enterocolitis, as well as other. So this led us to our final paper that has been just recently released, and we were able to look at these associations by state and region. So for this, yes, sorry. Sorry.
I think it was just somebody unmuted by accident. You can go ahead, Dr. Ware.
Okay, sorry. Because I don't see a chat or myself or anything. So please interrupt me if you need to.
Okay, you can
Um,
go ahead.
Okay, so this study, we were able to look at state and region, and we were able to go for a 3-year cohort of babies from 2016 to 2018. So we had nearly 10 million infants included. We did the same exclusions as the previous studies: less than 500 grams, less than 7 days, and deaths due to malignant neoplasms or congenital anomalies. The exposure again was initiation of any breastfeeding as noted on the birth certificate. And we divided this outcome as either 7 to 364 days or early post-perinatal death in those first 6 months, because that is when the most of the infant mortality does occur in the first 6 months. And again, looked at lots of covariates. I know this slide is too tiny to really see, but this shows how we excluded various categories: less than 7 days, malignancies, etc. The California and Michigan births also came out. So our final cohort was 10 million live births and almost 20,000 infant deaths, and most of them were early infancy. Again, our demographics were similar to our nation. And I just want to highlight that the post-perinatal infant mortality, if you look at non-Hispanic Black and non-Hispanic White, those numbers look really low because, again, we have taken out those exclusion categories, but you can still see that 2 times increase in Black infant mortality and compared to white infant mortality. So by our characteristics, we looked at breastfeeding initiation and infant death. And for each characteristic, you can see there's lower breastfeeding where you might imagine it and higher infant mortality. So for the less than 20-year-olds, 72% initiation and an infant mortality 3.87, compared to your 30 to 34-year-old mothers with 87.4% initiation and only 1.53 infant mortality rate. And it held for all the characteristics in a significant way, including our racial categories. And then we were able to pull out information by state and region. So Georgia, of course, is in the southeast, and we have 383,000 births over that 3-year period, over 1,000 deaths. Great breastfeeding rate for Georgia in initiation, and the total post-perinatal death rate was 2.64 for the 7 to 364 days. And this is kind of what I think of as what my TIPQC leader used to call the money chart, where you can this is what you want to look at. So this is looking at all the odds ratios divided out by region, and in the left side is the total infant death, 7 to 364 days, and on the right, the early infant death. And just at a glance, you can see most all of the adjusted odds ratios, which are the dot, are on the left of 1. So less than 1, which is a protective effect of the initiation of any breastfeeding. Some of the confidence intervals, which are the lines, do cross over 1. And but most of them, as you can tell at a glance, are protective for breastfeeding. When you pull out just the regions, I snapshotted these for you. You can see that all the regions have a reduced adjusted odds ratio, and some regions more than others, with the most reduction in the Mid-Atlantic and Northeast, but also even in where we are in the Southeast, a reduction. And you can see I added the breastfeeding rates to go along with those regions overall. And then the early infant death, the same findings. And then so for Georgia, this is your data for those 1,011 deaths. So we have an adjusted odds ratio for Georgia 0.81 with a confidence interval 0.7 to 0.93. And then 857 of those were in the early infancy time period with, again, a 0.82 adjusted odds ratio. And when we look at this from the odds chart, the R chart, you can see here Georgia sitting nicely and completely less than 1. And again, for the early infant deaths, less than 1. So when we look at the summary of all these studies, we can see that on the right-hand column, we have all the adjusted odds ratios for the initiation of any breastfeeding. Looking at all the possible confounders that we did, we have a reduction in post-perinatal infant mortality. So the implications of this are that breastfeeding saves lives and that breastfeeding promotion, protection, and support are really key to infant mortality reduction initiatives, and that eliminating disparities in breastfeeding may help to reduce those disparities that we're seeing in infant mortality. And the Lancet has said that if 823,000 lives of children less than 5 could be saved if breastfeeding was scaled up. So that's really, I can tell that's the heart of all the work you're doing in your group. And I just wanted to acknowledge the co-authors helping on these last 2 papers. Very honored to work with all of them. So what can we do about this? I'd like to encourage all of you, if you're not already, to join your infant mortality efforts in the state and the local areas. There's FEMUR teams, fetal infant mortality review teams locally that you can get involved with and help be a reviewer of cases. Cradle Cincinnati is our collective that works on infant mortality reduction in our area. And we need to be, as a breastfeeding promoter, at the table of these various initiatives working on infant mortality. This was something that grew out of our connection with our infant mortality reduction initiative in Memphis. They helped us to launch our first billboard about breastfeeding in Memphis because of our connection and realizing that we needed to work together. The state and local health departments are really key because they have all of our data, and we know that public health begins with breastfeeding. And I just wanted to point out that we're just talking about initiation in these studies. So what would we find out if we could grab the data and look at continuation, duration, exclusivity? You guys are doing great in Georgia with initiation. I just wanted to share this little QR code of some videos that we made for Cincinnati area for those families who may not have decided yet to breastfeed. And they're very short, and you might enjoy looking at them. And you guys are doing a lot. I'm just preparing for this. I was so excited to learn about you, what you're working on, and you have my favorite people in the world, Rose, right there with you, who are really working on this disparity issue with breastfeeding. So Georgia has it going on for sure. And I'm thinking about you being in Appalachia, part of Georgia. There's a lot going on in the Appalachian Breastfeeding Network, and they have a hotline. I hope you know about their hotline. We use it for Ohio now, and it makes a difference for a mom to talk to somebody at 2 in the morning who's trained in lactation support. And I hope everyone's already a member of the United States Breastfeeding Committee. If you're pediatricians, I hope you are a part of the section on breastfeeding and are using the new AAP breastfeeding curriculum for your learners, and that you will join, if you haven't already, Academy of Breastfeeding Medicine and your state and local breastfeeding coalitions, because you can make a difference and save lives. And then once we get them started, we know that we have a drop off. So we have to do all we can because breastfeeding is a universal solution that levels the playing field, giving everyone a fair start in life, preventing malnutrition, ensuring food security, and breaking the cycle of poverty. So it was really an honor to talk to you all, and I'm going to see if I can stop sharing because I'm not seeing how where my button is to do that. Okay. There I go. Thank you
Thank
guys
you, Doc.
very much.
Thank you, Dr. Ware. Do we have any questions or comments from anyone?
I had a question. That was a wonderful presentation. I was curious, in your study that you published last year, that the effect on kind of the more mature infants, those that are not the tiny babies in the NICU, when you look at them in terms of neonatal and postnatal mortality, is pretty striking. And I wonder if you could, looking at any breastfeeding, one of the things in breastfeeding initiation, but continuation, there's a big difference in terms of achieving and continuing. I wonder if you could give your thoughts on kind of the impact of continuation that might be relevant to those impacts on kind of postnatal mortality or late neonatal mortality.
That's a great question. We want to do that study when we can figure out how to connect to that data, because we know that probably some of the differences we saw in certain areas, like in the Memphis study, for instance, we those social determinants of health, the other factors that are impacting families that we can't pull out of a birth certificate are not being accounted for. And so if we could at least measure the breastfeeding, we I feel like we've just scratched off the tip of the iceberg on the effect of any breastfeeding. And so we really want to be able to look at uh, continuation, intensity, duration, exclusivity, because we know it varies in different populations for sure. And then we want to be able to know more about the social determinants of health, and then we can grab off the birth certificate to tease some of that out. Um, so it's a great question, and we want to know more for sure. Because once we get them started, it takes all of it. I mean, what you all are doing is wonderful, but we all have to be on board to help moms continue to breastfeed.
I just wanted to thank you, Dr. Ware, for taking the time to connect your work to our situation and stats and public health picture here in Georgia. And that's, our objective in having you come present was to help our initiative connect the work we're doing, every day at the bedside to the bigger picture. So you did a wonderful job of that. Thank you for taking the time and care to give us a really customized presentation.
Well, you're doing a great job, and really, it's exciting to see. So keep going.
Thank you.
All right, any final questions? All right, I have a couple final slides for us, just some reminders and important dates. If you have not completed your August audit, our numbers are a little lower than we typically see. So if you haven't done that yet, please do your audit. If you're not sure if you did complete it, I know August is kind of a blur sometimes, you can reach out to Linda and she'll let you know if it's been submitted. And then your September audit is coming up due September 25th. And then we will see you October 10th for our October webinar. But do not leave yet, because we need to make sure you log your attendance. So you can scan the QR code, or I'll grab the link and put it in the chat if I can rotate between all of these different things. And just make sure you log that you attended today. And thank you, everybody. I'm also going to put the conference information in the chat right now. Here's your attendance link.
I'm happy to share this slide. Someone asked about that. I don't know if they meant mine or Dr. Patel's, but I'm happy to.
Yeah, that'd be great. I can combine them together and we can put them in our team site. Thank you so much.